with the surgeon that was giving it, so you've gotten me. And the topic is periprosthetic fractures. Again, you know, with the aging of the baby boomers, a lot of hips and knees going in, and then revision hip arthroplasty, people falling down. This is just a big problem you're going to see in your practice. If you go do an upper extremity fellowship and you take a little call on the weekends when you get going, you're going to have to think about periprosthetic fractures. You're going to see a lot of them. Again, you see my disclosures. So this talk's going to just touch on classification, but not beat it too much, just enough to get you thinking about the fracture types and different methods to solve each type. And then I'm going to talk a bit about traditional treatment, you know, the way I did it the first decade of my practice, and how I've moved to a different treatment now that I think is more useful and less morbid. So what's the true incidence? Well, it's unknown. I think somewhere between 0.1 and 2.5%. We do know that 80% of periprosthetic fractures are in women and 20% in men. And the baby boomers are aging, so you're going to see a ton of this stuff. And we're getting more primaries and revisions, so more fractures. Get ready. They're coming. What about the patient? Just like the acetabular fracture patient I just talked about. Poor host, multiple medical problems, poor bone quality. They almost all have metabolic bone issues, right? Nutritional deficits. I mean, which one, you know, you think all these patients are on a paleo diet and eating all the right fruits and veggies? Heck no. My grandma, I'd go over and see her and she'd say, Matt, when you swing by Wendy's and get me a double cheese with fries, you know, and because, I mean, they're done. And they're just going to enjoy the rest of their years. And then they got, you know, the inside is just as old as the outside. You look in the mirror, they don't look 18 anymore, where their gut's not 18 either. It's not absorbing any better than the rest of their body's functioning. And they got renal problems with parathyroid, and they don't get in the sun that much. So they all have vitamin D issues, compounding their postmenopausal and hormone deficiencies. And then, you know, when they break, if they've got loose stems, you get medullary osteolysis and granulomas and cavitary lesions and stem loosening. It's just a mess. The arthroplasty creates a stress concentration. So you see the majority of these fractures are at the tip of the stem and moving up and down the stem. And thankfully, because those are actually the easier ones to fix. So that's one good thing. If you look at just back in 1999, I think that this was the study that kind of highlighted my thinking. Bills and Tower, they looked at 93 periprosthetic fractures. It was multiple surgeons doing multiple stuff, depending who was on call. And they followed for 5 years. And through this, they came up with a classification and a general strategy, which I use. I like it. And basically, I like it because it's simple. It says, hey, look, if the implant is unstable, that's the hip or the knee arthroplasty, you got to revise it. And if the fracture's unstable, you got to fix it. How simple is that? So you just look at the implant, you ask yourself a question, do I have to revise that thing? Nope, looks well and grown. Good, I'm just fixing the fracture. Or I got to fix the fracture, but man, that thing's loose. I got to revise it too. And then there's a Vancouver classification. You need to be aware of it, I think, but I'm not even going to go through all this. You can look it up on ViewMedi or whatever you like to look at and go from there. So what are the types? Well, there's the type 1, which is around the trochanteron. This one's pretty stable. You don't have to fix all of these. This would be the Vancouver A. And then the type 2 is in the center of the stem. And then the here's a type 2. So this one, let's look at it. It's a well-ingrown stem. It was a hemiarthroplasty, got some bone ingrowth. It's fairly stable. So there's no need to put a big allograft strut in the front and strip out the front and a big plate on this side. You know, just use the fixation that's right for the fracture. And this one, it just was a long spiral. It needed a few cables and to stay off it, and it did well. And then the 3s are the end of the stem, and they're very common. This is most of Beals and Towers were the type 3s at the tip of the stem or the tip of the stem and then going up the stem. And here's a typical 3A, which is the tip of the stem. But look, the stem's well cemented. I'm not doing anything with that. Now this one won't take a cable, right? Short oblique. This one you're going to have to put a plate on. And this is what I did in the early part of my practice around 1997. There were no lock plates. And so I was just cabling them. Cable the top and put screws at the bottom. But I was doing a pretty biologic-friendly technique, not overstripping the fracture. So you can see that medially, you know, there's some nice callus forming over here because it just left it alone. And it kept the patient off it. So the conventional way isn't bad. I'm going to show you a way we've moved to that's better with locked plates, I think better. But this worked as well. Here's a 3B. This is the most common type where it's at the tip of the stem and then kind of moving up the stem. And here's, you know, a classic. You don't see many of these anymore. When I was first in practice, people were still putting a lot of, the Austin Moores were still alive when that was done. And so this is one of those. But you look at it, you say it's a fairly reasonable fracture. You might argue that the stem could come out too because it's the old style unipolar stem. But the patient had a lot of issues, and I just wanted to get in and out, and was just a household ambulator. Traditional treatment would be cabling the top, screws at the bottom, keep them off it, biologic-friendly technique. It works, just through a direct lateral approach. And then the type C's and 4s. The type C is at the end of a revision stem. The type 4 is well away from the stem. And when you see that, boy, that's just a happy day. I see that one, we'd make our rounds. I see, is the stem involved? Nope, it's way down at the bottom. Yes, because it's going to make an easier day. Here's an example of a fracture at the end of a revision stem, but extends, if you look closely, way down in here. So you say, okay, hold on. How am I going to grab the distal fragment and go all the way up and bridge it all? And now you'd say, well, fine, I just use a lock plate construct. There's all sorts of them in the market, but back in 1997 when I did this, we had blade plates and dynamic condylar screws. And that's what I did, and, you know, using sort of older traditional treatment, I got lucky on this. But if you were really be critical, say that plate should be longer, and it should. And what's that cable doing there in the zone of injury? I really struggled with the reduction of this fracture, so I said, oh, the heck with it, just bring it over the cable. But I know that's a violation. But we went on and healed this, thankfully. And here's another one, a type 4. You know, you see the fracture here, but it extends all the way distal. So you've got to solve the distal and the proximal portion all the way up the shaft as well. And again, this was my treatment back in the late 90s where I'd use a dynamic condylar screw and run the plate up the side and try to be as biologically friendly as possible, maintain the blood supply to the fracture, and this solved it. Well, let's look at this now. So if you look at Bills and Tower in 99, they had a 41% complication rate. 41%. Who's going to do an operation where nearly half of the time it fails? That's a problem. And so there was a lot of room for improvement, and they were treating some non-op, and 45% of those deformed. If they used a cemented revision, you'd guess that'd go onto a non-union, a bunch of hot cement right down the fracture. So if you're going to revise it, go uncemented, the component. And their fixation was failing all over the place, you know, 13% fixation failure. A lot of their fixation, if you look closely at the study, were big allograft struts in the front, cabled in without a plate, and they called that fixation. So that really is not a good solution in this day and age. Okay? And now, we're not having a 40% complication rate using lock plates and biologically friendly techniques. So if I was sitting there listening to this, I'd say, okay, then what do we use? Screws, cables, screws with cables. What kind of screws? Locked, non-locked? I mean, what's the answer? It's bewildering. There's a lot of options. Well, Dennis looked at this, and he showed that if you use up around the stem a combination of screws and cables alternating, either unicortical or bicortical screws sneaking behind the stem, that's going to be the strongest fixation, D, strongest pull strength. So that's what we do. And then just like any AO technique, what's your goal when they come in? Restore length, rotation, and alignment, early motion, function, just like any fracture. I'm just going to move through a bit of this and get to these. Okay, so if you can draw it, I think you can understand it. So more and more I draw things to see if I really can figure it out. And this is a sketch I made. If you do an axial section through the mid-diaphysis of the femur, and here I represented the femoral stem in cross-section, you know, because of the shape of the femur, with the linea aspera, it comes back, there's plenty of bone posteriorly. I was cabling everything proximally, thinking I can't get a screw past the stem, but you can get a screw past the stem. If it's a non-lock screw, you can sneak it behind the stem almost every time and get good fixation. And you can angle the screw 20 to 30 degrees within the plate. So if you just cheat that plate a little posteriorly, you can get some purchase, okay? And this works. What if they have tremendous porosis or a big revision stem in there. You don't have much bone to work with. And so with a traditional plate, I drew this out. I tried to represent this. Hey, George, will you see if Tracy can ask him about the construction? See if we're going to be dealing with that. I don't know if we can do anything about it, but if we just complain a little bit. So if you put the plate here now, and you got a big revision stem and not a lot of bone posteriorly to deal with, you can't get the angle of the dangle to come back behind it. But some of the companies now make these extensions like this that come off the plate for periprosthetic fractures, so you can get a screw behind, even in that scenario. I'm not allowed to mention the company's name, but ask around to the vendors for periprosthetic fractures. There's some really good tools out there now to solve these problems. All right, what about lock plate versus non-lock plate? George, also tell me when I'm at 15 minutes, please. Thanks. So how does a conventional screw fail? Well, if you're using conventional screws, we all know that you're relying on compression between the plate and the bone. And so if you don't have a good bite with your screw, this is non-lock fixation now, it's going to fail because you don't have a good compression between the plate and the bone here, okay? And so how does it fail? Well, typically the first screw fails, and then you get sequential screw failure, and the whole thing just falls apart. And that's an unhappy x-ray when you see that. What about lock fixation? Well, I think lock fixation is great for parotid bone because you're no longer relying on the plate to be stuck to the bone intimately. It's an internal, external fixator, right? And since the screw is threaded into the plate, for this to cut out, it has to cut out catastrophically straight out, not as likely, or cut out big swaths of bone, because they're fixed angle devices. And this is where it really helps you. This is your friend now, osteoporosis. I don't think lock screws is that useful in young, healthy bone. You can get great fixation with standard screws. It's in the parotid patient. It's in the fragility fracture where locking fixation has really changed my practice. And so let's just compare this. If you look at a young, healthy buck, 18-year-old male, and you say, I'm going to use non-lock screws, bicortical and lock screws, it's only about 40% stronger. So you say, I don't need it in a healthy bone. But if you look at parotid bone and use non-lock screws bicortical versus locking screws, it's nearly 100% stronger. And that's saying something. So what kind of plate do we use? Well, where's my time? Okay. Locking 4 or 5 broad combi hole plate. Let me say that again. For the femur, if you've got a periprosthetic femur fracture, they come in curved varieties now. If you just ask the company give me the periprosthetic fracture set, it's all there. It's not the narrow 4 or 5, but the broad, curved plate. And I like the combi hole plate because you can alternate the cables that go into the plate. Whoop. The cables, so you see you have a unicortical screw, then a cable, unicortical screw, or you can sneak screws behind the prosthesis, non-locking. These are locking screws. And then for above a total knee, instead of a retrograde nail, I like a locking condylar plate because you have that short little parotid metaphyseal segment attached to the total knee, and you got to get a bunch of screws in that. And lock fixation is good for the parotid bone. So here's an example now of what I do. It's a long plate, alternating screw, cable screw, or a screw behind, and then distal it can be bicortical screws, and this is lock fixation. Here's a patient who had this done at another institution. This is their second ORIF of a periprosthetic fracture. This is an 85-year-old female who is diabetic and rheumatoid, on steroids, 2-pack-a-day smoker, Camels, unfiltered. And of course, this is not going to heal. And she breaks it. So we have this. So now they need their third operation. If you look at this, you say, well, maybe the fixation, maybe it's not just biologic, like I told you, telling you she's a bad host, but it's just cables, and there's a big allograft strut here, and maybe it just needs more fixation. So the issue with this, for these, is go long with your plate, okay? I went all the way up and down the femur, spread those forces, grafted the heck out of it, and kept her off it. I got a little paranoid, put the allograft strut in front. I usually don't do that because you have to strip anteriorly, but I just thought that I wanted this to be her last operation. She went ahead and healed. We got lucky. So when in doubt, go long with your plate as well. Here's an example of a physician who used a narrow 4 or 5 plate, a short plate, and then a lag screw in a fracture that's not laggable. You don't need any fixation at the zone of injury. This screw's not doing anything. And so as they're walking on it, it's gonna fail. But you see it wants to heal. It wants to heal. Am I at 15 minutes, George? Okay, this will be my last case. It wants to heal here. When you see that, you know the biology's fine. You just got to make it mechanically more stable. Longer fixation and spreading the forces out over the fracture. And so what did I do? Hardware removal, mechanical fixation, long 4-5 plate. You can use anything biologically. You want to use iliac crest bone graft, I think that's useful. I use cancellous allograft with BMP on this particular case. They've now got stem cell concentrates you can use, and I think they all are useful. But there's the long plate. Intraoperatively, approximately alternating cables and screws. And so just by going long, the length of the femur all the way down, gaining stability, we can gain union. What I want to just do for the last 2 minutes, instead of showing all these cases, is I'm going to zip to the very end of the talk, because I want to show you what's happening with morbidity and mortality. The reason I'm doing this is because I want to set an example for the rest of the people giving lectures. I don't want anybody to run long. So if I'm willing to not run long, we want to get everyone to their lunch and breaks on time. So I looked at 97 periprosthetic fractures of my own in 2004. It was a prospective cohort control study. Average age was 80 years, just like Towers and Bill's. 80% female, 20% male. 70% total hips, 30% total knee. What happened at 3 months? 96% healed. So if you look at Towers and Bill's where they had a 40% complication rate, we've improved. And this isn't just happening in my hands. If you look at some of the series, the union rate has gone way up by doing sort of the technique that I'm describing. We can get these folks to heal. So now we're all heroes, right? Well, not so fast. 35% of my patients were dead at 1.5 years. Okay? So you know, like a hip fracture, the old adage is you come in through the pelvis and out through the hip in life. Hip fracture was traditionally the beginning of the end. I think it's the same for a periprosthetic fracture. These are old, sick patients, and this is not a minor thing that happens to them. And something happens that we may not understand. It's sort of the beginning of the end, a slow degradation and a failure to thrive. And so we may be able to get the fractures to heal better, but we still haven't sorted out what's happening to these patients and why it's still a very morbid and mortal problem, periprosthetic fractures. Thank you for your time.